The glycopeptide class, which vancomycin is a poster child for, has certainly been around for a while. Over the last, actually it's been a while now, maybe 20 years plus, there's been a development of the lipoglycopeptides. Hence the name lipo shows that they have a long lipophilic side chain that provides a number of different features associated with them. From a clinical perspective, those features are noted in terms of much more improved or lower what we call MICs, minimum inhibitory concentration levels. So for example, where vancomycin may have an MIC of 1 to Staph aureus, this will be fourfold lower, 0.012 or lower in some cases. So you actually, to say you have more activity, you just have much lower MICs, which provide just better killing when you have marginal tissue distribution, which can happen in necrotic and abscess-based areas. So it allows for, certainly that. Another feature is with that lipophilic side or the lipoglycopeptide cases, you actually have a very long half-life. So very often that half-life is greater than 7 days. So you can give a single dose of this antibiotic IV and then walk away, and that can be the equivalence of 7, even 14 days of IV and or oral therapy. So again, it allows a nice option rather than having someone come in getting the standard of care of vancomycin twice daily IV. You can give them a single dose of dalbavancin. They get their dose. They're now sent home, and that's the equivalent of 14 days of IV vanco. So it does provide some flexibility with these patients where you can choose to have a patient that's going to either be non-compliant or their disease is more complicated for oral therapy, but you don't necessarily have to admit them and you can send them home. Now, the clinical trials looking at the lipoglycopeptide class did actually select for a moderate severity of illness. So again, we mentioned some of those, but in the dalbavancin trials, 85% of those patients had a fever, 40% had a leukocytosis. Many of them met SIRS criteria based on that New England Journal article, and many of them actually were treated as outpatient therapy through the ED. So we know from the clinical trial we have some support that these patients do well at home. What we do at our facility is twofold. One is we always get blood cultures in everybody, and we have a mechanism to call them back should something change. And second, we make sure that within 5 days they have a follow-up to have their wound checked, to make sure they're actually having regression of their disease and improvement, so we know that things are better. And that's often the big issue is, yes, you can give them this antibiotic, send them home, but you need that follow-up so that they can come back and actually get evaluated and make sure the antibiotic is working appropriately. And that's really the big trick for us. We have a great avenue for having them have follow-up. I will tell you that many of these patients never show up because they're just a difficult group to manage. And they really, again, are often homeless, living outdoors, no stable address, active psychiatric and drug use. They just don't like to come back even if you give them an appointment in 5 days. They just sometimes don't show up. The dosing administration for the lipoglycopeptides is actually really easy. So again, the glycopeptide class, like vancomycin, you're used to giving a single dose, say for example a gram, twice daily if you have normal kidney function. That dose is usually run in over an hour or longer, and it's IV. The nice thing with the lipoglycopeptide class, like dalbavancin, you actually give a single dose once. So rather than a dose twice a day for 14 days, you can give a single dose once, for example, 1,500 milligrams. Instead of it being run in over an hour, it's actually run in over 30 minutes. And that's it, and you're done. And you sort of can let the patient go, and they can go home. And in the studies, that was equivalent to 14 days of IV vanco plus or minus oral therapy, depending on the patient. So that sort of allows, it's basically a single dose providing 14 days of care, of therapy, which is, again, really great. No need to have them admitted and have IV therapy twice daily. No need to worry about compliance and oral therapy when they go home. And again, those patients had a moderate level of severity of illness, with greater than 90% of those patients having some systemic sign of illness to be enrolled in that study. So it actually provides a nice option of a single dose over 30 minutes where they can then be sent home. There are 2 cases I remember recently of successful outpatient therapy with a long-acting glycopeptide, in this case dalbavancin, at our institution. Recently, we had one gentleman who came in, had a moderate abscess on his shoulder. This was an area where he actively was using methamphetamines intravenously. It was about 6 to 7 centimeters. We did a debridement in the emergency department. admitted him to the medicine service because, unfortunately, with his methamphetamine use, he was having active psychiatric disease. And over the ensuing 2 days, he received IV vancomycin. His lesion continued to slowly get better, but again, he had active psychiatric disease, and by 48 hours in the hospital, he was actively suicidal. Generally, that, again, means he's not going to be discharged. Even though his skin and soft tissue infection was slowly improving, he was not able to be discharged for his psychiatric disease. And we did get lucky in this case where a bed opened up at one of our long-term psychiatric care facilities. Unfortunately, that place does not administer IV antibiotics. So it became a nice opportunity to then transition from IV vancomycin. We gave him a single dose of dalbavancin. That then allowed us to remove the IV and no longer administer IV therapy for his skin and soft tissue infection, and he was able to get the appropriate psychiatric care and detox that he needed associated with that. So again, he was admitted, but it allowed for an early discharge. The other patient, which we thankfully have a few per week, and this is sort of a standard patient we will have at UC Davis, it's a younger gentleman, early 20s, again, usually living outdoors, doesn't have a stable address, develops a skin and soft tissue infection. This one was actually on the buttocks, and he was mostly sleeping outside, also actively smoking and injecting methamphetamines. The abscess in the buttock was drained by surgery, and the emergency department was well packed with care, and he had access to come back within a few days to get his wounds changed on a regular basis in the surgery clinic. But again, he had really no other comorbidities other than his social issues that limited him. Stable blood pressure, normal lactate, was febrile when he came in, but during his time in the emergency department, his fever reduced. We gave him a single dose, 1,500 milligrams of dalbavancin over 30 minutes, and then we were able to send him home and discharge him directly from the ED with the ability to follow up for wound care. I will tell you, this gentleman, and the reason I saw him back, he did not follow up for wound care for a few days. Surprisingly, his lesion in his wound without following up for wound care got better. He just, again, unfortunately used methamphetamines, had a psychotic break, had a run-in with the law, and then was readmitted to my ICU as part of a complication of his altercation with the police, where we were able to reevaluate his wound. That looked like it was getting better, but unfortunately came back for other reasons.